Dr. Ravini. May I now invite the President of the College of Pulmonologists of Sri Lanka, Dr. Ravini. I think she's here.
Yes, I'm here, Dr.
The next speaker, please, for the college lecture.
Right. Thank you, Dr. Arisha.
Yes, please.
Thank you. Good afternoon, everybody. I'm delighted to be able to introduce the next speaker at the college lecture of the Sri Lanka College of Physicians. She is Dr. Ruan Ki Jayasekara and is currently employed as an acting respiratory physician at the National Hospital of Sri Lanka and at the Central Chest Clinic, Colombo. She has several areas of special interest in respiratory medicine, which includes sleep medicine, non-invasive ventilation and critical care, and also palliative care in respiratory disorders. She has obtained accreditation in sleep medicine from the European Sleep Research Society and has been conferred the title Expert in Sleep Medicine in the year 2020. Her interests are not limited to only curative medicine, but also to palliative care, and is a member of the Sri Lanka Medical Association's task force in palliative care. She is competent in procedural skills, which are important in the practice of respiratory medicine, and also has many publications under her name. May I now invite Ruwanthi, who is an up-and-coming star in respiratory medicine, to deliver her lecture. Over to you, Ruwanthi.
Thank you very much, Madam, for your kind introduction. I would like to thank the Sidon College of Physicians for giving me the opportunity today to present on the topic of chronic respiratory failure before YouTube. I chose this topic today because patients with chronic respiratory failure are encountered in all specialties of medicine, and the field of its management is enhancing. Most of us manage patients with respiratory failure, especially in the COVID pandemic. We were exposed to patients in respiratory failure, but are we doing it right? And do we have the right knowledge to identify a patient in impending early chronic respiratory failure? So I have put together this presentation to share the knowledge and experience I have gained during my local training at the National Hospital of Sri Lanka and Central Chest Clinic, Colombo, as well as during my overseas training at the Royal Papworth Hospital, Cambridge. So there's a lot to do before YouTube, and even if the decision is not to tube. So this is the outline of my talk today. We will first go through a few cases, and then we will discuss the management of each of these cases as we go on, starting from case one. So this is a 51-year-old male who was fit and healthy and being an army major, suddenly notices that he trips and falls and gradually progresses of these symptoms over 9 months. He presents to the neurology team, who do further investigations with a nerve conduction study, EMG, MRI, brain, spine, CSF analysis to get to the bottom of it, and he gets the relentless diagnosis of motor neuron disease. He also has a whole genome sequence to identify whether there is any genetic association with early onset motor neuron disease, but it is negative. He is referred to the respiratory team, and we do the lung function test, respiratory muscle assessment, arterial blood gas. He's normocapnic in the initial state, and we plan to do a sleep study to identify nocturnal hypoventilation. However, with this daunting diagnosis, the patient is in denial and he is lost for follow-up until we meet him again after about 10 months. We meet him again about a month ago on a chair, sitting on a chair in the corner of the ward. He's very short of breath. He has progressive weakness of his upper limbs and lower limbs. He has difficulty in swallowing, and he refuses to go into the bed. He has difficulty in lying down, and even a slight inclination causes breathlessness, and he has been sleeping on the chair day and night for 10 months. We do a chest x-ray, arterial blood gas, and this time he is hypercapnic with bicarbonate retention. He is in chronic respiratory failure. So how do you manage this patient? We'll discuss management as we go on. Let's move on to case number 2. A 50-year-old female with a background of bronchial asthma. He gets referred for uncontrolled asthma. But when you talk to her, she says she has exertional breathless and orthopnea, which has developed over the past 2 months. We do a chest x-ray to look at what is going on. And you can see that there is right side, the hemidiaphragm is elevated. We do lung function test, standing and supine, ultrasound diaphragm and EMG to identify diaphragmatic dysfunction. And when a patient comes with diaphragmatic dysfunction, we have to know why this has happened. So we dig into her history and we pull out this chest X-ray, which was done a few months before her symptoms started, and there is no diaphragmatic dysfunction. We talk to her again, and then she says, and she remembers that she had developed a painful rash 2 months before her symptoms, suggestive of herpes zoster. So we sent her to the neurology team, who also do nerve conduction study and the diagnosis of herpes zoster neuritis of the phrenic nerve leading to diaphragmatic dysfunction is made. She also has an arterial blood gas of hypercapnia with retention of bicarbonate in chronic respiratory failure. How do you manage her? Case number 3, a common scenario patient, or 68-year-old male who's a smoker coming with recurrent exacerbations of COPD with this typical chest X-ray of hyperinflation, and the saturation is low in their 80s, and the patient's arterial blood gas is shows hypercapnic respiratory failure. So when do you start NIV or non-invasive ventilation in this patient group? Moving on to case number 4. 70-year-old female with progressive breathlessness and long-term dry cough, who has this chest X-ray and HRCT with a diagnosis of idiopathic pulmonary fibrosis, and you do an arterial blood gas, she is hypoxic with a normal carbon dioxide level. You go through the clinic book and find out that she has been having low saturation for some time. So how do you manage this patient? So we will move on to discuss evaluation of chronic respiratory failure, during which we will be able to plan the management of these patients. So chronic respiratory failure can be lung failure or pump failure, or a combination of both. There is impairment of oxygen diffusion. There's impairment of the pump mechanism, diaphragm, and the intercostal muscle weakness. And when it comes to respiratory failure, you very well know it's type 1 and type 2 respiratory failure, and the type 1, where there is the partial pressure of oxygen is less than 8 kilopascal, and type 2 respiratory failure, where the carbon dioxide is more than 6.5 kilopascal on top of hypoxemia. So let's take the first group, the type 2 respiratory failure, where there are several causes. It is not only the traditional COPD, but there is also other causes like the neuromuscular diseases, chest wall diseases, skeletal deformities, obesity, hypoventilation syndrome. All of these groups of patients can come with type 2 respiratory failure. So let's take, to evaluate, we need to evaluate each of these group of patients to start proper or to commence on appropriate management. So in this, when a patient comes with type 2 respiratory failure, the question is, when should you initiate NIV? So to explore this question, let's take each group of disorders separately, because there is a subtle difference with the etiology. So neuromuscular disorders, Duchenne's, Becker's, congenital dystrophies, myotonic dystrophies. So this is a group of disorders where there is gradual progression of respiratory muscle weakness, which is inevitable. And we know that when a patient is hypercapnic, we have to start on non-invasive ventilation, and application of NIV in hypercapnia in this group of patients has shown survival advantage. So daytime hypercapnia is a definite indication for starting NIV, but is it the correct time to start NIV? Before the development of diurnal ventilatory failure, or before the patient develops hypercapnia in the daytime, there is nocturnal hypoventilation. First, it starts in the REM sleep, where there's hypoventilation, then it progresses to the non-REM sleep, and then it spills over to the daytime. So waiting for the patient to develop ventilatory failure in the daytime exposes the patient to the risk of uncontrolled decompensation. And you know very well, when a patient comes with deterioration, and to start NIV at that point with the background history of a neuromuscular disorder, it can be very challenging, very daunting to the patient as well as the medical team taking care of the patient. So several studies have done to look at the correct timing of NIV. So I will take a look at this study by Ward et al., which was published in Thorax. In this study, 48 patients with congenital neuromuscular disorders and chest wall disorders were randomized. And these patients were normocapnic in the daytime, but had nocturnal hypoventilation. They were randomized to either receive non-invasive ventilation or for standard management without NIV. And they were followed up for 24 months. At every 6 months, they were monitored, and you can see clearly the white dot is the group that received non-invasive ventilation, where the transcutaneous oxygen has nicely improved, whereas the control group has persistent hypercapnia. And look at the percentage time that they spent where the TCO2 is more than 6.5. There is nice control in the group receiving non-invasive ventilation. There's improvement in saturation as well. So after the study, there were several studies which led to changes in guideline recommendation. So non-invasive ventilation in this group of patients should be introduced at the time of symptomatic nocturnal hypoventilation. Waiting until the development of daytime hypercapnia exposes to uncontrolled and unpredictable decompensation at the time of chest infection or other intercurrent event. Let's move on to motor neuron disease. So in motor neuron disease, you know, it's a relentless disease with poor prognosis, where palliative care has to be started with at the onset of the diagnosis. And few randomized control studies are available to look at the survival benefit of NIV on MND. So I would like to quote this study from which was published in Lancet, Effects of NIV on Survival and Quality of Life in Patients with Amyotrophic Lateral Sclerosis. In this study, they showed an overall benefit or overall survival benefit on the group receiving NIV. So there was 92 patients who were eligible to be participated, and they were assessed every 2 months. They were randomly assigned to either non-invasive ventilation or standard of care. So the patient group without severe bulbar dysfunction who received NIV showed an improved survival rate and improved quality of life, and the median survival benefit was 205 days. The patients with severe bulbar impairment, the NIV did improve the quality of life, but did not show a large survival advantage. Moving on to chest wall disorders, kyphoscoliosis, pectus excavatum, flail chest. So this is a group of disorders that have a slowly progressive disease. There's a group of disorders which are slowly progressive, and they ultimately go into chronic respiratory failure. And so the evaluation and the timing of the non-invasive ventilation is the same as in the other groups that I discussed before. So now we know that we have to time the non-invasive initiation of NIV a little early. And how do we know whether the patient has developed nocturnal hypoventilation? And for the assessment, again, as in any other medical illness, we will start with the history and examination. So symptoms to detect potential respiratory muscle weakness. You ask in the history for fatigue, poor concentration, respiratory symptoms of breathlessness, orthopnea, recurrent chest infections, sleep symptoms of non-refreshing sleep, daytime somnolence, morning headaches, and you do a clinical assessment. You look at the respiratory rate, you assess for a weak cough and shallow breaths. And all these features are suggestive of impending respiratory failure. And you look at the saturation. If it is 94% on air, that will give you an inclination that the patient's respiratory muscles are weak. You go on to do the lung function test, respiratory muscle assessment, cough peak flow, and nocturnal saturation and transcutaneous carbon dioxide monitoring. So let's start with the spirometry. It's mainly the forced vital capacity that we are interested. So in these patients who go into respiratory failure over a long time, they have to be monitored serially, and we have to look at the longitudinal decline, we have to do a longitudinal assessment. We have to look at the serial FVC values to look at the trajectory and identify where they start declining. So the FVC less than 50% or less than 80% with symptoms is suggestive of respiratory muscle weakness. And you can do the FVC seated and supine and look for a more than 10% decline in the value to assess for diaphragmatic dysfunction. And also, when you do the lung function tests in patients, if you come across these funny flow or volume loops, now this is a normal flow volume loop, and look at this, where the expiratory volume loop shows oscillations, where the patient hasn't been able to maintain a good conceal. And there, in this graph, the inspiratory flow has abrupt stopping. So if you see these kind of flow volume loops, think again whether this patient has respiratory muscle weakness. So this is the spirometry study that was done in the patient, in our first case, the patient with motor neuron disease, progressive weakness, and has been sitting on the chair for day and night. And we have done, you will see that there is restrictive pattern of weakness. We have done the seated and supine forced vital capacity, and you can see the change. It is 25% significant drop in the FVC, indicating diaphragmatic dysfunction. This is the spirometry of the patient with herpes zoster neuritis of the phrenic nerve leading to diaphragmatic dysfunction, standing and supine FVC again. There is a 47% drop in the FVC, so very significant diaphragmatic dysfunction in this patient as well. So when the forced vital capacity starts dropping, you have to make sure that this FVC drop is due to respiratory muscle weakness. Therefore, you go ahead and do the respiratory muscle assessment, and these tests are available in the government sector. It is available in the central chest clinic. So you do the maximal inspiratory pressure, you check the maximal expiratory pressure and the sniff inspiratory pressure. In the bottom graph, you can see this patient who is getting the respiratory muscle assessment, the MIPS and the MEPS, and you can see that he has to maintain a mouth seal to do this test. You know that when they have bulbar muscle involvement, they can't maintain a good mouth grip, and then you can do this sniff inspiratory pressure, the upper picture. So if your MIPS and MEPS are less than 40 centimeters of H2O, or if it is less than 60 centimeters of H2O plus any symptoms, that would indicate that the patient has respiratory muscle weakness. So this is the respiratory muscle assessment that was done in our patient with motor neuron disease, where the maximal inspiratory pressure is 48 centimeters of H2O and the maximal expiratory pressure is 55 centimeters of H2O, quite reduced, indicating respiratory muscle weakness. Also, now if the patient finds it difficult to lie supine, for you to do the seated and supine forced vital capacity, when you look at your MIP and MEP, also you can get an idea about the diaphragmatic dysfunction. When there's a significant reduction in the maximal inspiratory pressure with relative preservation of the maximal expiratory pressure, the diaphragm being the main inspiratory muscle, this will give an indication that there is a diaphragmatic dysfunction on top of the intercostal muscle weakness. Then you can go on to do your sleep study to detect nocturnal desaturation and nocturnal transcutaneous monitoring. So you can look for episodic oxygen desaturation and elevation of transcutaneous oxygen. So to summarize what we have gone through so far, so if you have a patient before you who has a likelihood of developing chronic ventilatory failure, you have to refer or do a respiratory evaluation at baseline. You have to do the clinical assessment, as I have discussed before, the lung function test, respiratory muscle assessment, chest X-ray, cough assessment, and depending on the clinical picture, you can plan the arterial blood gas and the sleep study. Once you have done the basic respiratory evaluation, we know that they are slowly progressive disorders. You have to follow them up. And this, depending on the trajectory or the natural history of disorders, natural history of the disease, you have to time the follow-up. So if it is a slowly progressive disease, you have to follow up every 6 months. If it is a rapidly progressive disease like motor neuron disease, you have to follow up every 2 to 3 months and repeat these tests. And apart from this respiratory evaluation, the ancillary management, secretion management, cough augmentation, swallowing assessment, physiotherapy, communication aids, they're very important, and each of these heading is a topic in itself. So the COPD group of patients that we commonly come across, COPD in chronic respiratory failure. When do you start home and IV in this group of patients? Let's take a patient who comes with acute type 2 respiratory failure to your ward. You do the medical management, but however, even despite your bronchodilators and oxygen therapy, the patient is hypercapnic. You have optimized management of right heart failure. The patient is in persistent chronic respiratory failure, and you start non-invasive ventilation. And let's say that you have managed this patient successfully, is normocapnic and is ready to discharge. So when do you start long-term NIV in this patient? So what you do is now in this patient who has been successfully managed, you optimize the management of COPD, you discharge the patient, and you review the patient in 2 to 4 weeks' time with a repeat arterial blood gas. And if that arterial blood gas shows hypercapnia and if it shows evidence of chronic respiratory failure, that is the time to discuss with him about long-term NIV. However, if the patient has recurrent documented evidence of type 2 respiratory failure, you can start on NIV, home NIV at that. So there are several studies which discuss the survival benefit of NIV on COPD patients. And I would like to briefly go through this hot HMV trial, which led to recommendations in guidelines. So this trial was done to look at survival benefit of NIV after exacerbation of COPD. So 116 patients were randomized either to home oxygen therapy or home oxygen therapy and mechanical ventilation or home ventilation, that is NIV. And when you look at this graph, you can clearly see the red line is the patients who have received home oxygen therapy, whereas the blue line is the patient who have received non-invasive ventilation or home mechanical ventilation. So you can clearly see the survival advantage when you look at this graph. So we have gone through now about how to evaluate a patient who has the potential to develop chronic respiratory failure. We know when to start NIV. So what do you do actually at the bedside? So now is the time to get our hands dirty. Let's take a peep at PEEP, EPAP, IPAP, etc. So the practical approach. So when you decide to start a patient on chronic NIV, it is best to start it in the daytime with a calm nurse, a confident doctor who can spend some time with the patient. For the first few hours of starting non-invasive ventilation is extremely important. Time spent fitting the mask and building the patient's confidence is well invested. Now, you can imagine how frightening it can be when a patient, if you have a mask strapped onto your face, all of a sudden with air blowing on the face and you don't know what to do, the patient becomes very anxious, and most of the time it's written that the patient is intolerant of NIV and his patient is deprived of this much needed treatment. So it's important to spend some time with the patient, talk to the patient, let the patient get accustomed to the blowing air and then put the straps on. Depending on the patient's central respiratory drive, you can either start on the S mode or the spontaneous mode or the spontaneous timed mode. In neuromuscular disorders and chest wall disorders, you can start with a low IPAP level of 12 to 16 centimeters of H2O and do a stepwise increase. You can put the backup rate just below the patient's spontaneous rate. You can start with the EPAP of 3 to 6 centimeters of water, but if the patient has concomitant sleep apnea, you can put a higher EPAP level. So the inspiratory pressure augments the tidal volume. The expiratory pressure is the same as the PEEP, and the difference between the IPAP and the EPAP is the pressure support. So higher pressure support will improve your gas exchange and your ventilation perfusion mismatch. When it comes to COPD, it is studies have shown that high ventilator strategy is better for COPD, and you can start with the IPAP level, quickly go up to more than 18 centimeters of H2O, and you can increase in a stepwise approach to achieve normocapnia. Usually you need an IPAP of about 20 to 30 centimeters of H2O, and if this is the value that has been required to control respiratory failure in hospital, you can subsequently use the same values when you set up the home NIV. Then once you've done the basic settings, there are these fine advanced settings, the trigger sensitivity, cycle time, rise time, fall time, and in the interest of time, I will move on. So you have done, you have set up the patient on NIV, and when you look at the patient, you see that he is struggling with the device or patient ventilator asynchrony. So you have to go and see what is going wrong. So you go to the bedside, you start from the airway, you start from looking at the mask, and many times we have seen in wards where a patient on NIV and on this vented mask, vents are the holes that are there for the patient's expiration to be expelled. So veins have been blocked by plasters, or non-invasive ventilators used with non-vented masks without expiratory ports. So then patient is drowning on his own carbon dioxide. There are tubes with cracks with plasters on it and the alarm is going off. So there are basic things that we can correct. And even after optimizing your advanced settings, if the patient is still struggling, you can do a sleep study with the NIV device to understand what is going wrong in the night. So even despite optimizing everything, especially in the group with neuromuscular disorders and chest wall disorders, if the patient is not tolerating your BiPAP device, this IVAPS or AVAPS mode is also another mode to try. It is a combination. So AVAPS is average volume assured pressure support. It is a combination of pressure support and volume assurance. So you set a target volume and you set a range of IPAP, and that has shown to improve the tolerance. So there are crossover trials comparing standard BiPAP with IVAPS or AVAPS mode. Even though there is no survival or mortality benefit, there's an improved overall adherence and tolerance with these devices. So during my overseas training, I was a co-investigator in this study with my colleague advanced nurse practitioner who was doing her master's degree, and this research was done for that. It was evaluation of the feasibility of AVAPS mode for commencement of domiciliary NIV for chronic ventilatory failure as day case in the COVID pandemic. I was in my overseas training during the height of the COVID pandemic, and when the patients had to start on home NIV, they were very reluctant to come to the hospital because they were a vulnerable group. So this study was designed to see whether the AVAPS mode could be started as outpatients. So so what we did was the AVAPS mode was commenced as a day case. The patients were trained to use, and they had half an hour to 1 hour to get used to it in the day case ward, and they were discharged home. They had a telephone conversation, a telephone follow-up in 1 week, and they had another day case review in 2 weeks' time. And all patients on this mode achieved their target PCO2 at the end of 2 weeks. And it was also interesting to know that the average IPAP was much lower than was conventionally used. And these diagrams I have borrowed from my colleague from her draft version. So now, moving on. Now, if your patient has required home NIV during the night, and now he has to use during the daytime, use 16 to 8 hours per day, and now that is the time to think whether the patient needs tracheostomy ventilation. This is a big decision, and it has to be discussed with the patient and the carers because it needs expansion of the care package. It needs a lot of training of the carers in tracheostomy management. So when we talk of neuromuscular diseases, motor neuron diseases, we have to talk about, we can't forget Stephen Hawking, who was the theoretical physicist and director of theoretical cosmology at University of Cambridge, and also the professor of mathematics at University of Cambridge, which is the beautiful backdrop in this picture. So he's a patient of motor neuron disease diagnosed at the age of 21, and he survived 40 years with this diagnosis and died in 2018 at the age of 76. So the scientists are baffled by how he survived so long, and it is thought that it is a combination of genetics and excellent clinical care. And during my overseas training, I also had the privilege of working with the same clinical team who is taking care of the respiratory side of things of Stephen Hawking. And during the COVID pandemic, his family donated his NIV device to be used at the Royal Papworth Hospital for COVID patients. So we have discussed about chronic type 2 respiratory failure, and I will have a few slides on chronic type 1, on patients with type 1 respiratory failure. So type 1 respiratory failure, patients are hypoxic, and when someone is hypoxic, you have to give oxygen. So you can give long-term oxygen therapy, there is ambulatory oxygen therapy, and short burst oxygen therapy. So evidence for long-term oxygen therapy is mainly coming from clinical trials on COPD patients, and these evidence has been extrapolated for to be used in patients with type 1 respiratory failure as well, such as in interstitial lung disease, lung fibrosis. Survival benefits have been shown when oxygen is given for severe resting hypoxemia or saturation less than 88%. And there is also improvement in dyspnea, depression, cognitive function, exercise capacity, and so on. The target saturation when you give long-term oxygen therapy for someone in chronic type 1 respiratory failure is 90 to 92%. There are many oxygen delivery devices, concentrators, oxygen cylinders, and it is a topic in itself. So the indications for long-term oxygen therapy is still the same from the age-old study and the partial pressure of oxygen less than 7.32 or partial pressure of oxygen less than 7.8 with the concomitant copulmonale polycythemia or right heart failure. What if your patient is having a normal saturation at rest, but has significant desaturation on exertion? Such as when you do a 6-minute walk test and you realize the patient is desaturating less than 88%. So in this group of patients, you can give ambulatory oxygen therapy. So the amount of ambulatory oxygen therapy has to be assessed by the physiotherapist, and we can give an oxygen prescription. Also, patients who are on long-term oxygen therapy and who desaturates more on exercise can have ambulatory oxygen therapy on top of the long-term oxygen therapy. Then there is the concept of short burst oxygen therapy, which is again standard practice in Western countries, where patients are given intermittent supplemental oxygen at home for a period of 10 to 20 minutes to relieve dyspnea, such as, for example, now our patient with idiopathic pulmonary fibrosis, he will become very breathless after going to the toilet, after taking a wash, after meals. So in these patients, the patient is given oxygen at a flow rate, maybe just 1 to 2 liters, or sometimes even 4 to 7 liters for about 10 to 20 minutes for relief of dyspnea. So there's evidence that short burst oxygen therapy shortens recovery time after activities of daily living. So I have been talking about the respiratory care in these patients, but for the total care, psychological health, pulmonary rehabilitation, smoking cessation, nutrition input, help with activities of daily living, home modification are all very, very important. So what I have attempted to do so far is to identify or evaluate patients with chronic respiratory failure. What are the investigations that we can do to identify them, and also to decide the optimal time to start on optimal management. So there is so much to do before YouTube, and so much to do even if the decision is not to do. These are my references. I would like to take this opportunity to thank Dr. Amita Fernando, Senior Consultant Chest Physician, who is my principal trainer, for his constant guidance and support throughout my training period. I would also like to thank Dr. Bandhu Gurasena, Consultant Chest Physician at National Hospital of Respiratory Diseases, who is my second trainer, and all the trainers who have been very helpful and imparted their knowledge to mold my training. I would also take this opportunity to say a special thank you to my supervisor during my overseas training, Dr. Ian Smith, who is the current clinical director at Royal Papworth Hospital, Cambridge. I would also thank my family members, especially my husband, for being a constant support to me. I have given my email address here as well, and if there are any questions, I am happy to answer to the best of my knowledge. Thank you very much for your kind attention.
Right. I'm not sure whether, because Ruwanthi was going to have some problems in actually, just give me a second. I'll just get this sorted out. Right. Ruwanthi was going to have some, Ravini was going to have some problems due to power shortages. I'm not sure whether, is Ravini here? Ravini? If you're not there, that's fine. She did warn me that she may not be able to stay on due to power interruptions. I think we have one question. From Danushka Bandarnayaka. What is the rationale of selecting CPAP and BiPAP in different clinical entities that were discussed? I think this question came halfway through the presentation, and it is quite possible that you may have addressed most of the issues. Do you want to add anything to that? Because I think this question came almost in the first half of your lecture. Do you want to add anything, or do you think you've spoken enough?
Just a brief sentence about CPAP is where you get continuous positive airway pressure during inspiration and expiration. So if I say briefly, the indications for CPAP will be obstructive sleep apnea, and also you can use CPAP when you're treating acute heart failure or pulmonary edema, whereas where you use non-invasive ventilation mainly to aid ventilation, to aid a ventilator failure when you want to address the issue of sorting out hypercapnia. So I think that is basically it.
Right. Thank you very much. I think that is all. Thank you so very much for a very erudite lecture. I think it was refreshing to listen to you and learn a lot, as well as recall some of the knowledge which had gone beneath the surface. So on behalf of the Ceylon College of Physicians, it is my great pleasure and privilege to thank you, as well as present you with the certificate of appreciation. We will make sure that you get this certificate in standard format to your hand in the coming future, but this is the e-certificate. So thank you once more. I hope you will continue to be with the CCP, support the CCP, and be part of its academic program development in time to come. And then before we wind up, I just wish to thank a number of people who helped this process. One is, of course, the 3 speakers, the 2 young physicians, as well as the consultant who delivered the college lecture, the 2 judges for the Young Physicians Forum, the audience which joined in large numbers, the CCP team which organizes all these things, including the full team, and then the IT team headed by Nadina. Thank you very much. And then I apologize again for this short notice of holding the whole thing via Zoom. These things will happen the way the country is. We have no idea what will happen by this afternoon. So hope you will have a pleasant day, devoid of any untoward violence. And let's hope that things settle and that we will move forward with more stability. That's a prayer that all of us are having. Let the violence end, and let we move forward with more stability and more humaneness. Thank you very much. I will take your leave then. Thank you very much, everybody.